introduce you to this great panel, and we'll get started. Dr. Brenda Fitzgerald is a board-certified gynecologist and a fellow in anti-aging medicine with a private practice in Carrollton, Georgia. She trained at Emory University School of Medicine and the Emory Grady Hospitals in Atlanta. She's been president of the Georgia Ob-Gyn Society and an assistant clinical professor at Emory Medical Center. She has served on the boards of Voices for Georgia Children, the Advanced Academy of Georgia, and the West Georgia Foundation, and chaired the board of the Georgia Public Policy Foundation. She served with Senator Johnny Isakson as a 7th District representative to the Georgia State School Board, and she was a visiting fellow at the Heritage Foundation in 1995. She has served as a healthcare policy advisor to Speaker Newt Gingrich and Senator Paul Coverdell. She was a major of the United States Air Force, serving at the Wurtsmith Air Force SAC base in Strategic Air Command in Michigan, and Andrews Air Force Base in Washington, D.C. She has served on the Military Academy Selection Board of both the late Senator Paul Coverdell and Senator Saxby Chambliss. She was a program chair for Leadership Georgia in 1989. Without further ado, Dr. Brenda Fitzgerald.
Thank you. I'm so glad to be here because I think, just as we were talking about at lunch, healthcare is one of the most important issues for solving the economic problems of our state and for making progress in our state. What we're going to do today is we're going to talk about the fact that healthcare seems to be one of the problems that the legislature has difficulty coming to a consensus about what to do. There are a lot of competing factions and a lot of people want to go in different directions. And certainly with the new federal legislation, this may be even more difficult. So this purpose of this conversation today is to talk about what we can actually do given the current environment to progress the solving of our health care and to make sure that we have consumer-oriented solutions to all our problems. Our first speaker is Nina Owcharenko. She knows policy and she knows politics. She graduated with a public science degree from University of North Carolina, Chapel Hill, and then she consequently worked for Senator Jesse Helms and for Jim DeMint and for Sue Myrick. She is now a senior policy analyst for the Heritage Foundation, and she writes extensively about Medicaid and about prescription drugs and about caring for the uninsured. So our first point of view will be from the national one from the Heritage Foundation. Nina.
Well, thank you so much for the nice introduction, and thank you all for having me here. It's always nice to get out of Washington and see what the real world is doing, which is always important, I think. I'm going to have to start off with the bad news, which is that Congress and the President enacted one of the worst pieces of healthcare legislation that we've seen in a long time. I think that the American people certainly wanted health care reform. I just don't think they signed up for the health care reform that actually was enacted. This new law takes us in completely the different direction from what Dr. Fitzgerald just said. It takes us away from a consumer-based system and moves us to a system that puts more power over decisions and dollars and care in the hands of Washington and federal bureaucrats. The American people know this. Businesses know this was a bad deal. We've got new mandates, new taxes, and probably miles of new regulations that businesses are now going to have to adhere to under this new law. That's a big challenge for businesses going forward, and it's going to be a struggle in the future. Seniors also knew this was a bad deal. We saw in record numbers seniors turned out in this election. Why is it a bad deal? Well, I'll give you one example. The massive cuts to the Medicare Advantage program, which is one of the private health care plans that seniors are enrolled in, over 7 million will lose their current coverage because of the new law. Physicians and other health care providers know this was a bad deal. Why? When you have more Americans dependent on the federally run health care programs in our country, you're going to test the willingness of good doctors and good health care providers from wanting to serve a system that underpays them at every turn. The taxpayers get it too. I think this whole law is known. It costs over $1 trillion in new health care spending. This was supposed to be a law, let's remember, that was supposed to bend the health care costs down. Somehow we start off out of the box by spending $1 trillion, adding new entitlements to a system that cannot handle another entitlement program, adds a $500 billion in new taxes that will be passed on to middle-class American families to pay for. So from the beginning, I think this has been a failure. And finally, the states get it, and that's you guys. Everyone here knows what a problem this has pushed on to the states. Massive Medicaid expansion and a federally designed mandated healthcare exchange infrastructure that's going to be force-fed down to the state level. This is going to be a problem for the states. You cannot get away from it. You can't hide from it, because as they're enacting this law, taking these provisions and then shifting those costs and those challenges to the states is not a solution for healthcare reform. So that's why we need the states now more than ever. I always say the debate in Washington may have stopped, at least temporarily, because of the enactment of the new law, but now that fight has transferred over to the states. This fight is beginning at the state level. We've already seen those states that have introduced the lawsuits against the new law, but now comes the new state legislature and what they can do to help figure out and mediate the problems of the new healthcare law and get our system actually back on track as well. I'm going to go over the two major elements that most states are going to have to face in the coming years and talk about what's in the law a little bit, talk about what are the consequences, and then start thinking, before we hear from Ron, brainstorming ideas of how do state legislators get themselves in line to have to deal with this in the new session. First is the Medicaid expansion. Right now, the new law allows some states, I believe Connecticut's one state that's already optionally expanded their Medicaid programs under current matching rates. So they're not getting any better deal out of this, but they're just expanding right now. But by 2014, every state in the country is going to have to expand their Medicaid program to 138% of poverty. A lot of people talk about 135, but they, of course, added an additional piece in the legislation that allows for 5% disregard of income. So when you add that back in, now you're at 138% of poverty. They have a mandatory payment increase for primary care physicians. I'm the first to tell you that people need to pay the Medicaid providers more, but I don't think that that's a long-term solution. And that federal funding that they're doing to kind of help keep states whole as they promoted this is only temporary. And so let's not forget what happens when those federal funds start getting pulled back little by little. Guess who's left holding the bags? It's the states. As I mentioned, the consequences, the federal bump is only, first of all, the federal bump in payment is only for new enrollees. So this isn't like, oh my goodness, now we're going to have new funding that covers all these new populations. Maybe states could have thought that was a good deal. No, it's only for newly enrolled individuals. Second of all, they add another kicker in there which says, and by the way, don't try to knock anyone off Medicaid to get the increased match. We're going to freeze eligibility in today's standards. So there is a maintenance of effort requirement and eligibility that puts states in a bind from day one to try to figure out how they're going to pay for all this. Second, they create a cliff effect. As I said, it's temporary funding. So as the years go out, it sounds like, oh, 90%, it's not a bad deal. Well, that starts to trickle down over after 2014. So this isn't permanent money. This is only temporary money. The costs, the matching rate, the increased matching rate that the federal government provides does not include administrative costs. I think at the state level, we know one thing and one thing well. It's the states that have to administer this program, and that costs a lot of money. So there's no administrative cost included. Second, the primary care bump that they're asking states to do, well, when that federal funding goes away for the bump, we're now in another situation that the federal government's in every year when the Medicare payments for physicians come in. They're going to have to figure out a way to either cut those reimbursements back to pre-Obamacare levels, or states are going to have to find the revenue to keep them at that Medicare level. And let's not forget that those increases were only for primary care physicians. So if you're a specialist, which I think in Medicaid, there are a lot of specialists who beneficiaries have a hard time finding access to specialists. They did not get part of this deal. So you can imagine the first people that want to get the same payment rates are going to be the specialists saying, if you're doing it for primary care and you're going to extend it for them after the bump's gone, you need to expand it to us as well. So that, again, is another cost. And finally, that wasn't considered is the whole idea of the woodwork effect. We know that there are millions of people who are eligible for the Medicaid program but refuse to sign up. When they now have an individual mandate into the law, those people are going to be flooding to the easiest option they can get, which will be the Medicaid program, to sign them up to say, I have qualified health insurance. Those people are going to cost the states. In addition, There's the whole issue of crowd out. There are a lot of people out there who are under the poverty level, who have private health insurance through their place of work, or they're buying it on their own, have done the right thing, tried to buy it on their own. Those people now have no incentive. Employers don't have incentive to keep those people on their health insurance plans. Why offer health care coverage when the federal government and the states will pick up the tab for the businesses? So you have a huge crowd out effect that isn't calculated into any of the costs that were given during the debate. So we have big problems with Medicaid. The federal exchanges, is still unknown box. The first thing, the federal government provides subsidies for states to start, or grants to states to start looking at whether they want to design a state exchange or allow the federal government to come and design one for them. So the first rounds of grants went out. Every state took grant money, I think except for one. It does not obligate a state to continue down that path. It's simply kind of startup money, grant money to look at your healthcare system. Then there are two options under the federal exchange. There's the American Health Benefit Exchanges, which are kind of the individual where the subsidies are going to run through, how the federal government's going to distribute the subsidies. And then their second is a Small Business Health Options Program. Now, those are two different types of exchanges that we still don't quite know how they're going to work together. Why? Because the number one consequence of this new law is it puts a tremendous amount of power and authority into the hands of the secretary to decide how this is all going to work. She can control what is a qualified health plan. She's going to be able to decide how the American Health Benefit Exchanges looks like. As well as what these SHOP plans, which are the small business plans, what flexibility states have or authority states have at all over what will come of this. And that is still to come. We still have no information about how these are going to be administered, regulated, or run. So it's right now still a very touch and go period. As I mentioned, one of the challenges and a consequence too is if states don't act, the federal government's going to come and do it for you. And some people say, well, let's bring them in, let's have them do it, we don't want our handprints on it. The problem is that is very consequential itself. Now you're going to have a federal government running health care across the country. If that is not a slippery slope to a single payer system, I'm not sure what is. Secondly, another consequence of this is that the exchanges, the one that most people know about, not the small business one, they're going to be in charge of deciding eligibility and determining eligibility for the Medicaid program. So if you want to turn that over to the federal government, that you can do. But I think there is now a tug and pull here with the states to say, gosh, I don't know if I want to turn that type of decisions over to the federal government. Is there room for us to do something on that road? So we have a lot of consequences and a lot of unknowns on the side of the exchanges, and I would not want to be a state legislator. You guys have a lot of work to do because these decisions are difficult, and as we already know, this law is consequential. This is not something that's going to happen in the future. The changes to the healthcare system are aligning right now because the law is now enacted, and there are consequences and damaging effects to our healthcare system that are already occurring today. And so we need to figure out how, at the state level, can we stop the bleeding and stop the damage from getting any further. So what are my recommendations from Washington? Not like anyone really wants more help from Washington, but let me try to inspire you. One, do your homework. States and legislators should know everything about their Medicaid program inside and out. They should know who's on their program, what are the demographics, what are the income levels that these people are. Break it down. Are they acute care? Is it long-term care? Figure out what your Medicaid program looks like and know it. Second, know the costs. Have people do studies, whether it's within Georgia itself, having outside people scoring and testing how much this is going to cost the state of Georgia. Look not only at the current window of what you're spending, but look what happens when those fundings start to go away, and then look out even further to say what are going to be our projected costs in enrollment in this program, out into 2020. Pick a year and say, let's look and figure out what this is going to look like for us. Information and knowledge is very, very important, I think, if we're going to stop the damaging effects from going any further. Second, same thing. Do your homework on insurance markets. Know what the situation in your state looks like. How many people are uninsured? Why are they uninsured? What does the business system look like? What kinds of health insurance do people have? Private? Is it individually purchased? Is it through their place of work? Look at everything. grasp right now what your premiums are today before that information is gone, because 5 years down the road, after the federal government continues to be manipulating what the real market prices are, we're going to forget what it was like in 2010. So capture that data and have a baseline ready for the future as things go forward. Third, hold hearings and do your effort to educate the American people and the citizens of your state about what's in this law and what the questions that legislators have to the federal officials. We've joked, but it's not really that funny. You should call down the secretary to have her explain the Medicaid provisions to your states or the state exchanges. How are these things going to go happen? Have people look at how is this going to affect our spending at the state level. Take your time and do due diligence on how to actually address this law now that it's been passed on to you. That is one thing that I think the Congress did not do enough, is really take the time and understand what the consequences were, and then having that information, maybe some adjustments would have been made. But at this point, where we are. Point number 2, develop a reform proposal that fits your state's needs. I know that there's a big law and everyone's trying to figure out how to fit into it. But as state legislators, you know best when you gather your data, when you gather your information, to develop a plan that fits the needs of your state. If you have a long-term care issue in Medicaid, focus on that. If you have a problem with people in and out of the marketplace and you don't know why people are churning through the insurance system, they have a job and have insurance, then they lose their job, now they're uninsured. 6 months later, they're back in the marketplace. Develop solutions that meet the unique needs of Georgia. Utah, Massachusetts, California, Colorado, every state is different around this country, and policy solutions, if they're going to be effective, need to meet the needs of the unique situation in that state. Second, look at the system as a whole, not in silos. Don't just look at Medicaid. See how the whole system as a whole could operate better as a healthcare system. Don't just look at the business side. Look at the uninsured. Look at the Medicaid piece. See how you can create a continuous system for healthcare over time. Maximize opportunities for states on authority and control. You've got to maximize what flexibility and what authority there still exists, and do everything you can to make the best of it. And third of all, when making decisions, try to figure out how to minimize your risks and your costs over the long term. I think that is going to be an important feature. Second, once you develop reforms, what kind of reforms? Well, we should be pursuing consumer market-based solutions to the healthcare system. That means a couple of key principles in my mind. 1, limited government involvement. 2, expanding business options. Looking at things like moving to a defined contribution system for employers so that it's not an all or nothing proposition for a small business with 15 employees. Either you offer health insurance or you don't. And now if you don't, you're going to pay a price. How can we figure out ways that would expand options for businesses like a defined contribution model? Third, establish individual portability, so that we can encourage continuity of care for individuals throughout their lifetime. One of our biggest challenges is we have a very mobile workforce and a mobile society. People are changing jobs and changing health insurance every time they change their jobs. That creates all sorts of disincentives in the healthcare system. We need to find ways of focusing on creating better portability so that people can own and keep their health insurance throughout their life. And fourth, we need to find a way to lessen the dependence on government-run healthcare programs, and for the states, that means Medicaid and S-CHIP. We've got to think innovatively on how do we mainstream people out of these welfare programs and into the private market, just as we did during welfare reform. The same should be true here. And 2 more ideas for the states to focus on how to encourage more from Washington. So you can do your homework. Now you should be forcing Washington to do some of theirs. 2 things. 1, demand new flexibility out of your elected officials in Washington. The maintenance of effort requirement, as I said, that freezes states' ability to touch eligibility should be removed and repealed. States cannot function and make the good choices that they need on the Medicaid program if they're frozen at eligibility levels as is. Not only should they ask for the maintenance of effort requirements to be repealed, but they should also be looking to get more flexibility. Instead, if we don't get more flexibility demands from the states, what's going to happen? It's going to be a demand for more dollars. And in this environment, there are very few dollars that can be spread around any longer. And I think You know, I caught the end of Steve's presentation, and it's true. It's been on a spending spree in Washington that has caused us to have the problems that we do. If states come back to Washington and ask for more money again, we are not doing anything to help our long-term economic problems in the country. So we need more flexibility from Washington and demand that rather than dollars. And fifth, keep pressure on Washington to repeal this whole bill. This next year is going to be critical to make sure that the federal officials do not just try to pass a full repeal bill and then move on to the next crisis. This is a crisis that is already having damaging effects, and the new Congress needs to hear from their state officials that this bill needs to be repealed because it will have damaging effects on the state as a whole. Communicating with representatives and senators and pushing forward and showing them that you, the state of Georgia, have your own ideas on how to fix health care for your states and your citizens. Tell them you have an alternative to what debacle that was created in Washington over this new law. So in closing, I just want to say the fight is not over. The challenge is now that we have handed the baton off to the states, and the states are going to have to fight this for us to make sure that the damaging effects don't continue and that we have better ideas and show that we know how to fix the healthcare system better than those in Washington. Thank you.
Thank you, Nina. Ron Bachman's our next speaker. Yeah, his knowledge about healthcare is deep and it's very specific. He got his Bachelor of Science in Applied Math from Georgia Tech and then his Master in Actuarial Science from Georgia State. He was a partner at PricewaterhouseCoopers, where he dealt with clients that were employers, HMOs, hospitals, and several federal and state agencies. He is now a senior fellow with Georgia Public Policy Foundation on Health Affairs and a senior policy with the Center for Health Transformation. In addition to that, he has his own company that called Healthcare Vision that is dedicated to the proposition that we need consumer solutions to our current healthcare. His topic will be, given the environment and this new law, what specifically can and should Georgia do? Please welcome Ron Bachman.
Let's see if I can pull up slideshow here. Well, Nina and I have presented at other platforms, and I think she laid out a pretty good case against the federal bill, but I'm going to take a little different tact. I would join her on all those issues, and you know, they have been spending like drunken sailors up there, but you know, Ronald Reagan had a saying, I believe. He said, it's an insult to compare them to drunken sailors because drunken sailors were spending their own money. What I wanted to do here was say, get over it. It's the law. We got to do something. We got to be practical as state legislators, as employers. What do we do to deal with it? I mean, again, I personally think it's unconstitutional and may very well be found unconstitutional by the summer as the Virginia case in particular goes forward. But in the meantime, we have to deal with it. We have to deal with public policy. What if it is found unconstitutional in July or late summer? Does Georgia have the laws underneath that? So if that goes away, some of the good aspects of the bill come into play, whether it's pre-existing condition standards, whether it's covering dependent children in a different way, maybe with lifetime maximums, there's mental health parity. I mean, there's a number of issues that are good in the bill. And what happens if that goes away for the citizens of Georgia? Because we quite honestly, before the bill was passed at the state level, we didn't have great safety net coverage. If you're on a small group, you didn't have COBRA for continuation of coverage. We just didn't have some of the allowances to provide protection when you're losing your job. And we've been in bad economic downturn for a good number of years, and people are losing their coverage, and they want to protect their home and their families. So what I want to try to do is lay out this. I'm an actuary by background, so I have a little formula for change here, and you can apply this in almost anything. In order to get change, you have to have three things in alignment. You have to have a desire for change. You have to have a vision, and that's your leadership. And then you have to have a process for change to implement it. If you have all those, you'll get change. But if you really don't have a desire for change, and actually the original was the pain was great enough. We tend to react to pain more than we do a desire for some great new vision out there. So, but I didn't like that, so I changed it to a desire for change. But if you don't have a desire for change, we can talk about a vision, we can talk about a process for change, but it never gets done. It gets put on the back burner. And so often that's what happens when people are trying to accomplish something. There's not a consensus and a real desire on a broad-based basis to get that change. I want to talk about some of the elements of vision: personal responsibility, behavior change, ownership, self-reliance, transparency, and a real focus on what I would call health and wealth, W-E-L-L-T-H. We want to talk about healthcare reform, even at the state level, around just the cost aspect of it. If you focus on the cost aspect of it, I think you lose the real issue and the moral responsibility to help our citizens be healthy, to save lives. That's the real, and if you do that, you'll save money. But if you go after just saving money first, you kind of lose the argument with an awful lot of the people you're talking to right away. What I'd like to do in this presentation is really kind of, conservatives for a long time been talking about personal responsibility. What does that really mean? What are we doing in terms of establishing personal responsibility? I'd like to bring that to life a little bit and say, what is it that we could be doing in the healthcare area with a state employee, a state health benefit plan, or with Medicaid to create personal responsibility so that people are healthier, or at least have the opportunity to be healthier. To me, personal responsibility, the other way I could think about it is tough love. If you got kids and you're enabling them to do bad things, they'll continue to do it. But sometimes as a parent, you got to have some tough love. You say, here's the restrictions, here's the guidelines, here's what you got to do, and you expect them to follow it. You expect them to develop a personal responsibility to be doing their homework in school or not getting themselves into dangerous situations, whatever it is. They have some personal responsibility, even kids. Well, we don't ask our citizenry to take as much personal responsibility as they really could or should. Now, how do we create that? Well, here's the determinants from the CDC. 50% of your health status is behavior. So we can talk about all these other things out there, access to care, the environment where you live, or your genetics, but 50% is from your behaviors. So how do we encourage people to have better behaviors? Well, people do want individual control. That's why I find it not very unusual that there's still more people are against this healthcare reform than are for it, even months afterwards, because there's a mega trend out there, and I believe mega trends are major forces that occur that are going to happen no matter who's in power. Now, elections matter, and we can advance or slow down some of these movements, but you can't stop them. For example, today people bank electronically at ATMs to have more control. Purchase stocks over the internet. I don't know why this is flipping all of a sudden. Purchase stocks over the internet, buy and sell goods through eBay, maintaining music on iTunes, personal videos on Facebook, going on all the way down, control their own TV on programs on TiVo. People want more control over their lives, not less. So why would they turn the most important aspect of their life, their most important asset, their health, over to somebody outside, and especially to the federal government or even state governments? You can't fight megatrends. Little Dutch boy can try, but ultimately that river is going to break through. It's going to go around the edges, whatever, but you can't stop megatrends. So what is the megatrend that we ought to be playing off of? And the fortunate part is one of the silver linings in the bill actually encourages something that I call healthcare consumerism. I'm going to stop it flipping. You have to bear with me while I be sure that it doesn't flip. I guess it's on some sort of timer. Trying to get me off the stage as quickly as they can, I think. Healthcare consumerism, I believe, is a megatrend. It's getting people involved in their own life. Now, here's the definition I like. Healthcare consumerism is about transforming a benefit plan into one that puts economic purchasing power and decision-making in the hands of participants. It's much more of a patient-centered system, not a government-centered system. It's about supplying information and decision support tools along with financial incentives, rewards, and other benefits that encourage personal involvement in altering health and healthcare purchasing behaviors. I really like that definition because I wrote it. The important part is that healthcare consumerism is not consumer-driven healthcare. Consumer-driven healthcare is a very specific type of consumerism, but it is not consumerism. It is only a selected form of consumerism. The earlier definition didn't say anything about high deductible plans. It only talked about personal responsibility and getting people engaged with financial incentives and rewards. You know, we're typically American. We want to get paid to do the right things, right? I mean, if just being healthy was enough, we wouldn't have rampant diabetes. We wouldn't have people still smoking. We know it's not healthy. But we want to get paid to do the right things. Now, will you reach everybody? No, but you'll reach a higher percentage of the population if you do that. So the unifying theme here is around behavior change. Now, I'm not going to get into all the different details of some of these slides, but I think either the Georgia Public Policy Foundation will have them up on a website, or if you call and ask them, they'll have this. I do have a little company, as was mentioned. I'm really retired, and some of my clients, as a partner at PricewaterhouseCoopers, said, no, you can't retire. I want you for policy and strategy work. So I set up that little company, so I don't really sell products or services at all. So I figure if anybody is crazy enough to want to read through my stuff, you're welcome to it. So I don't claim any intellectual property whatsoever. But there is a generational process that's going on as we're moving in this mega trend. We're sort of in the second generation around focusing on behavioral change, but there are third and fourth generations, which again I don't have time to get into today. But it's a very consistent process of moving us to a better world and a more healthy world. Well, consumerism is independent of plan designs, and the amazing part is that it lowers costs, improves quality, enhances choice, and expands access. Silver bullet, amazing. Do you really believe it? Well, here's a report from the American Academy of Actuaries. I'm an actuary. Last summer, a bunch of geeks like me got together, took a look at all the data on consumerism plans, the account-based plans, which are the main ones out there. And they came up with this. It was nonpartisan, came out before the health care bill was passed, and it was totally ignored. Totally ignored. Now, the first year savings says you can drop the cost as much as 12 to 20%. Wouldn't that be nice? But it also says you can lower the trend by 3 to 5% a year. So it really does lower the cost curve. Cigna just came out with their report that I got a copy of on their choice fund. It actually goes beyond that. They're seeing even better numbers, year-over-year savings, so it's not just a one-time savings. Their latest report shows their experience is showing a 16% drop on their customer base. What happens with that? Are we cost shifting? No, we're not cost shifting. We're actually doing better on preventive care services. That makes sense. You want to help preventive care services so people don't get into the higher cost. And so more of these plans actually have preventive care services. Chronic care is treated more effectively, and physician treatments are following more evidence-based protocols in these plans. And there's more care avoidance. Well, in this evolution of encouraging personal responsibility, we've sort of gone through a process of plan design. And years ago, said, oh, those plan design just for the young and healthy and wealthy. And that was probably true to some extent, but we've advanced beyond that. Again, the generational chart that I showed you earlier says we've gone into more education, decision support tools. But the incentives and rewards now, this idea that we're typically American and want to get paid to do the right thing, information alone is not enough. You have to have some sort of a financial stake in the game. And we've been experimenting with that in the real market out there of employers. We tried participation. Well, guess what? The same people who run also engage in the corporate runs and get a reward or an incentive, so it didn't really help anybody. We tried engagement. Okay, well, I'll sign up for something and get a credit, but they don't really pay attention to it. We're working our way down here, and the latest thing that really seems to be having a big impact is health status. So we call that biometrics: blood pressure, cholesterol, nicotine use, body mass index. Just think about a population where all four of those are in the right levels. I don't know that there's any doctors out there, or many doctors, if there are any, that wouldn't tell you that we know what those ranges ought to be for each of those four items. It's not a big dispute. Now you can set up easy-to-reach targets and moderate targets and more aggressive targets. But if we use health status, for example, we're seeing an enormous amount of savings. Well, in the healthcare reform bill, amazingly enough, again, the silver lining, the current law allows for a 20% of the premium to be used as a reward or incentive. The new law takes that to 30%. So they actually did the right thing there. And it gives the secretary, who has all this power we talked about before, the ability to go to 50%. So we have a really good tool to sort of personalize and put some life to what personal responsibility is. And if you don't want to do it, fine, but you may have to pay more. But you can buy back any additional cost by having some personal responsibility. If your blood pressure is high, you got a great plan. Go get your blood pressure medication. If your cholesterol is high, go get your Lipitor. It's all covered by your plan. So why shouldn't you do it? Why do we want to enable people to have bad habits? I mean, if we really focus on wanting to help people, we would say, of course, we ought to be doing this. There's some other biometrics. The first four are the most common, but there are some others that are developing out there, the A1C and waist size. So what's the potential savings? Well, here's a chart that says as we move into these future generations, and according to how much we put in decision support tools and other background information, we can save up to 30% at least. Now, we're currently in this area here of the blue line. It's like 5 to 8%, and we're seeing in the studies I just mentioned 12 to 20%. So it's very consistent with the numbers here. So you can be very conservative and say, gee, we ought to be saving at least 5 to 8%. Well, let's take a look at the Georgia State Health Benefits Plan. I know it's a very complicated plan. I don't know all the details of it yet. I got a feeling Brenda's going to make me learn a whole lot more about it over the next few months. But we got 680,000 people in that plan. I know there's like 6 different systems out there. Actual state employees, only like 30% of the enrollment. You got all these other people that are in there, teachers, et cetera. So this is how many we currently have. And we do have some programs in there, both in United Healthcare and Cigna, that have the account-based structures. But again, healthcare consumerism doesn't rely on having those designs. Well, what have we done in Georgia? From the data that I looked up, actually, because we've had a difficult time in financial shortfalls, we've been kind of eating our seed. We've been drawing down on some of the reserves that we have out there that are typically available for a healthcare plan, because when you have a healthcare service, you pay for it many times a month or more after that service. So you have to have reserves in place. Well, we had that, and I think we've been eating that up because we haven't had the funds, so we're a little bit more on a pay-as-you-go basis than on a real financial solid ground as we really should be. So let's take a look. Just take some numbers here. Let's say the cost for state of Georgia employees is $3 billion, which I don't think is too far off. And let's take that savings range of 5 to 8% a year and a trend savings of 2%. All these are low numbers compared to what real employers out there are actually experiencing. Well, over the 4 years of this administration, and that's why I picked 4 years, what could be the savings? Take 4 years times a 5% low cost estimate, 4 years times the extra 2% savings, that's 28%. We'd save $840 million. And if we had the high range, you're at $1.2 billion. So if the state legislature is really serious about finding some money, you know, there it is. Now, have you got the guts to go after it? Have you got the guts to actually say we're going to actually have people required to put in some biometrics and to try to meet them, and we're going to reward and incent you? You know, to me, up to this point, we've been enablers of bad health. Now it's a matter of you going to put in some tough love. I'll wrap up here in a second. What would be some other impacts? I believe that Georgia has a retiree health benefit liability that was mentioned in one of the earlier sessions. They called it OPEB. I believe that's somewhere between $17 and $20 billion. Unfunded liability for promises to provide retiree benefits. Employees use biometrics to establish the contributions of the employees, saving them lots of money. So let me stop there. I'd be glad to answer any questions. I think the other issue for those who actually have to think through all this and work it is that when you face a problem, there are 2 ways to think about issues. And the first one we're all really good at, including myself. It's what I would call the no because crowd. You show me something, and the immediate reaction from most people, no, that can't be done because, that can't be done because of this, that can't be done because of that, that can't be done because of political issues, that can't be done because. The other, but the problem with that is that immediately shuts down any discussion because it's pejorative. There's no reason to discuss it. It can't be done. You can have the same concerns, but you approach the problem with a yes-if approach. Yes, that could be done if. And all of a sudden now you're brainstorming new ideas and new thoughts. And I think that's sort of where Brenda's committee on some of this transition, I hope, is really their mindset is that even though there may be some barriers and issues, we approach it from a yes, that would work if, and then find the answers to that. And all of a sudden you got the creative minds working on real solutions. Let me stop there.
Great, thank you, Ron.
I know there are questions. Who'd like to go first?
Well, Ron, I'd like to ask you about how we can maybe look to applying the healthcare consumerism ideal into the Medicaid population, and is that a way we can start impacting some of the state health costs on Medicaid?
Yeah, especially since under health reform, I think Georgia's supposed to pick up 700,000 people into the Medicaid system. Big cost. You know, the numbers that we saw promoted in Washington during the debate was only the Washington cost. They didn't include all the state costs. My suggestion, again, and some of it may be a no because, but we find some yes ifs in this. I would require drug testing for every Medicaid beneficiary, not to eliminate them from Medicaid, but to identify them to get help and treatment. Again, if you're really concerned about people's health, identify them to where they really are and where they need. I would include the biometrics, the same as for the state employees, in the Medicaid program, so we have a consistency of using biometrics in both areas. And what I would do there, I would set them up, I think, and say, you got to meet 2 out of the 4 in order to qualify for extra benefits or some reward or incentive. And I don't know exactly, because of the maintenance of effort conditions under health reform, whether you can say, okay, well, we're not going to provide some of the things that aren't required, like dental or vision or some other areas, unless you meet the 2 of the 4. If you don't take care of yourself on health, why are we going to spend more money over here? Again, you have some personal responsibility. That's what the whole idea is. How do we bring to life and structure personal responsibility as the driving force in any of these programs? If you don't want to do that, why do you expect somebody just to keep enabling you with your bad healthy habits or your drug issues or anything else? It's time to step forward and say, no. At some point, this country's got to say no to some things and change the way we do it with the same idea that we want to help people who really need help.
Can I add one more thing? I think what Ron says is so important, especially if we could do this. Right now, the federal government is overwhelmed with this new law. It now has to figure out how to implement this 2,000 pages. It is so imperative for states who want to start doing different ideas, like what Ron's pointed out, to do it immediately and get that up and moving. It will be much harder for a federal official to say no after you've already gone down and done all your homework and did the right things and have a plan that would work, for them to say no, rather than just saying, well, I'm just not going to do anything because it's kind of doomsday.
Next.
I must miss the logic in your comments, Ron. Are you saying that by withholding the enablers, that people will automatically get better and will visualize that 20 to 30% savings? So
no.
Hence, I would ask my wife to give up her high blood pressure medication in order for her to get better?
No. You misunderstood, or I didn't say it very adequately. I think we've been the enablers of bad habits because we haven't really structured what we mean when we keep talking about personal responsibility. It's just a phrase out there that we've never really given life to. So what I'm saying is that if people under Medicaid, for example, or a state employee, part of their job is to be healthy. I would say that we would really have success with this concept when, and I don't know exactly the right term to use, but from most companies talk about their human capital, and that's usually thought of as a top-down sort of view. My human capital is the most valuable part of my company. when we as individuals understand our own human capital, what is your human capital? It's your education, your experience, your creativity, your job experiences, all those things. But if you don't have your health, all that other stuff goes to waste. It gets diminished pretty rapidly. So the idea that we want to help people help themselves is that part of their job is to be healthy and take advantage of the programs that are there. So no, you would want your wife to take her blood pressure medication, because if she's part of a group and everybody in that group, wherever they're starting today, I don't think they're all within those standards. What I'd say is that if they get in those standards, we're going to save a lot of money. So it may mean that those people who have high blood pressure and are not taking their medication would wind up paying higher premiums. It may be, in most of these programs, you put them in, what the employer market has been doing is they put them in about 6 months in advance, and they tell people, here's what's going to happen. Now, go to your doctor and get your medications and get your numbers of blood pressure, cholesterol in line, and then you'll qualify for the extra benefits or the rewards or incentives that come from that. So it's, if I heard you right, it's almost the opposite of what you were taking.
Yeah, the way I heard it, and I think I'm another one that was listening sort of that weird filter, was that, going back to Nina's point, well, the Secretary of Health and Human Services can then say, well, we'll just cut back on certain medications and people will adjust their behaviors. I just didn't want that
No.
No.
if I was the only one hearing it, I apologize, but what I'm trying to say is we don't want to mandate by taking away people's medications and
No, 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 no.
Right.
No.
And this is, the beauty of it is it's not mandating anything, it's setting the environment so that you're more likely to reach a higher percentage of whatever that population is. And if they don't want to do it, then they ought to have to pay more or forego some extra benefit. Again,
Yes,
we're
ma'am.
typically American, we don't get paid to do the right things.
Let me, while we're bringing the microphone over there, let me as a doc say something that's probably interesting. All of you should go to the CDC website, go to CDC statistics, and look at the increase in weight in the American population over the last 20 years. It's frightening. Right now, the number of Georgians who are overweight or obese is 60%. So if we have some differential cost for if you take your blood pressure medicine or if you exercise or if you quit smoking, then that would be a tremendous benefit to the cost of our health care. Because obviously, healthy people cost less.
The state of Georgia has a surcharge for non-smokers. We're kind of used to that in a lot of insurance. What I'm saying is there are other biometrics that are not debatable, that are very healthy, that we can do the same thing with. Like Alabama has used the 4 biometrics I mentioned as part of their premium structure.
Yes, ma'am.
Most of these factors, these biometric factors, are pretty cheap to calculate, but the cholesterol level and the, what is it, A1C, aren't those are initial out-of-pocket costs for the person doing it, whether it's the employee or the Medicaid system. About how much would that be per person? Do you have any idea of what and is that an objection on the part of anybody implementing these systems to do the testing?
I personally, I would cover those costs for those medications at 100%.
And I got to tell you, again, as a doc, waist measurement and weight will do about 95% of that. Just.
I was just going to try to answer that question. The easy way to do it is incentivize the easier way to do that, I think, is incentivize a physical every year, and all that information is naturally taken in the physical exam, and so you have it for free, and also gives the individual the information about their health and health status, and we also can use that if they permit us to, and track those biometrics.
One of the beauties of applying that same concept to the Medicaid population, it seems to me, is they would have to go get a blood test from a doctor. I would not take it from an emergency room, for example. All of a sudden, we've been struggling for a long time to get people to find a medical home. So how do you connect them? You know, you almost got to walk people to the doctor and say, hey, there really is a doctor here. This is somebody you can go to, and your benefits are covered. And so by doing the biometrics and giving them rewards or incentives, and at the Center for Health Transformation, we had Gallup do surveys around would that population be responsive to rewards and incentives like the employee population is in the commercial side? And the answer was absolutely yes.
Yes, sir.
In
doesn't plan to fund, Obama don't plan to fund this until after his proposed reelection, and even if he did, wouldn't the new Congress plan not to fund this, and it wouldn't go into effect?
Nina, you want to speak
Well, I
to that?
think that right now with the House of Representatives and even a Senate, which is kind of a mixed group now that have faced a tough reelection or maybe facing one coming up, I think right now the House is looking at how do they move forward a full repeal bill and then looking at how to take apart the bill piece by piece. I don't see major progress in getting a full repeal before a potential new administration comes in.
I was talking about not funding it. I found since I've been in the appropriations that if nothing's funded, nothing happens.
I think that certainly there will be efforts, aggressive efforts in the new Congress to try to stop funding for major elements of getting it implemented. Whether those make it to the president's desk and he signs them into law as a stop of his own health care plan, I think is more unlikely than people realize. I mean, this is a cornerstone of his reelection, is to talk about the success of the health care bill. And anything that would prevent it from going into effect, I think would hit some resistance from him. However, you could easily start arguing the point that that any of these spending limits and any of the new tax hikes should be delayed until we get our economy back in order. And that puts us in a different scenario. So I think that maybe a better alternative is to say, you may, Mr. President, have had some good ideas in this health care bill, but we can't afford them right now. So let's delay and put it off as long as we can.
The good news is the smartest guy on health care in Washington is now head of the budget committee starting January. It's a guy named Paul Ryan. He's absolutely brilliant, and he'll control the purse strings. The interesting part is that what most people don't know, has not been much talk about, is there's something called the doctor fix. On December 1st of this year, Medicare reimbursements for doctors are going down 20% if something is not done. It should have been part of Obamacare, but they kicked it down the road because it cost $250 billion and it would have put him over his $1 trillion limit that he put on. If they don't do anything on January 1st, it's going to go down another 6.5%. So this new Congress coming in, I think is going to, I think actually in lame duck Congress, they're going to probably kick it down the road to the new guys come in and say, okay, all you Tea Partiers don't want to do deficit financing. How are you going to deal with this? Because nobody wants doctors to be reduced by 20% for the Medicare program, because 30 to 40% of doctors said if that happens, they're not going to take any Medicare patients. And so how are we going to fund that? That's a big issue. It's going to come up right away. Now here's my suggestion. You might know whether it's even possible. I don't know, but I figure if Paul Ryan can figure it out, maybe he could use this. There's subsidies under the exchanges that go up to 88%, $88,000. It covers about 58% of the population will be eligible for some subsidies in these health insurance exchanges. I checked with some congressional contacts, and well, how much is that worth? And I was told it's worth about $450 billion. So what I would do is I would package those two together and say, we got to save Medicare, but we don't need to put those subsidies in right now. We just can't do it. And quite honestly, I think if they don't put any subsidies, you basically kill the exchanges and you kill Obamacare.
You could also do something clever, as other people have talked about, even with the Medicare Advantage cuts, offsetting them with a delay even in the expansion of the Medicaid program, which costs money up front too. So there's a lot, I think, of combination effects of stopping the spending as well as delaying the implementation of those key provisions.
You have 159 new departments, agencies, councils, committees, workforce groups that could be defunded, I think.
All right, I'd like to ask a question for the general legislators here. If, given those ideas that you've had, and given the fact that obviously there are going to be some moves to delay implementing this entire plan, with our current legislators coming in, what percentage of their time should be spent on dealing with this new Obamacare or this new federal health care law? I'm sorry, that was. And what percent of their time should be spent on deciding what Georgia should do just anyway? Can you give us a percentage?
Oh, for us?
Both
I
of
thought
you.
she was asking the
I
audience.
did too. I was
Or you guys. No, I'm asking you guys.
I think that it is, I think that it needs to be more on doing what Georgia thinks is right for Georgia. That should be the most amount of time that is spent. You got to walk and chew gum at the same time. You got to know what's coming down the pike, but I think most important is to be ahead of the game. Even though this new law is enacted, It's got a slow startup, so states that are aggressive in moving forward faster may be able to outrun it.
I think that in this current General Assembly, we ought to be thinking about two things. One is the assumption that Obamacare, healthcare reform, is found unconstitutional. And if it is, then where does Georgia stand? Because we didn't have very good insurance laws prior to that. And there's a package of ideas that have been out there for a while. I think they ought to be considered and implemented, if nothing else, as a backstop that, again, includes some of the issues that Georgia has been talking about for a long time and some of the things that are good aspects of the healthcare reform. The other is to take a look at some of these ideas for the state employee health benefit plan and Medicaid. Now, the real advantage we have in Georgia is that we have as governor probably the leading expert in Medicaid. And if any of this can be worked around, if there's any yes-ifs around the Medicaid part, Nathan Deal will be able to figure that out.
All right.